Greetings, everybody. This is Jana Eubank from the NAT Policy Shop. Welcome to Washington, D.C. Lots happening here. And welcome to the third Policy and Advocacy webinar. We're really thrilled that you were able to take a little bit of time out of your afternoon. We've got a lot of good information to share with you today. There's a couple of housekeeping items I just want to review with you really quickly before we dive into the presentation. First of all, the audio today is going to be provided via computer, so please double check your computer speakers to make sure that they're working, and or just plug in your headset to listen. You can adjust the volume of the audio on your computer by using the audio broadcast control box that's indicated in the slide. Now, if you're having issues with your audio and you can hear this, please send us a chat in the chat box, and we will contact you directly to help you troubleshoot those issues. The second piece is the webinar is going to be recorded. I think people have really appreciated us putting this on our website so you can share this information, these presentations, with your board of directors or community members that are interested in advocating for health centers. So know that this is going to be recorded, and you can access these recordings at the website that's listed on this slide. We will be sending the link out of this recording in the Washington update that we send out every week, and so that will be coming out early next week, so you can be anticipating that. Now, the other thing, I know a lot of you are going to have questions. There's a lot of complex information that we're going to be sharing with you today. No question is a bad question. So if you do have an issue or something that you have a question about, please use that chat box, again, to ask your question. And I would do it at any point in the webinar. We are going to hold questions until the very end, but I think it's always a good idea to get your question in the queue. And we do really want to see all of your questions, and we're going to do our best to respond to them. But if we do save these questions that we receive from these webinars, and if we're unable to respond to them during the webinar, we will follow up with you individually. So as I mentioned, there's a lot going on in Washington. We're going to cover a few different things today in the presentations. First of all, the administration has been up and running. The new administration has been up and running for the last month, and they've been incredibly busy. So we're going to have Colleen Myman, our Director of Regulatory Affairs, give you a brief overview of what's happening with the administration, including a conversation about what's going on with the executive orders that he has signed that have a direct impact on community health centers. Then we're going to have John Sawyer and Jen Taylor from our Federal Affairs Shop go over where we are currently with our priority issues and strategies, and specifically we're going to be focusing on health center funding and the health center funding cliff and where we are with that, as well as Medicaid, which has obviously been a hot topic here in D.C. Plus, in this month, we're also going to touch on workforce, and that's specifically the National Health Service Corps and the Teaching Health Center program, and kind of where we are with those two things. And then finally, we're going to turn it over to our top-notch advocacy team, Dorian Wanzer and Elizabeth Kwanzik, who are going to provide an advocacy update to let you know what you can start doing right now to advocate for your health centers and for your patients. We've also developed some new resources and tools that we want to share with you today. So at this point, we've got a lot to cover. I'm going to go ahead and turn it over to Colleen, who's going to give us a little regulatory overview. Colleen?
Hello, everybody. I'm assuming you can hear me now. As you've all known, if you've been checking the papers, there's been quite a bit of activity in the past month in terms of the new administration actually issuing executive orders. My experience has been that normally the first month or so of the new administration tends to be quiet, but this is certainly a non-traditional administration that's come in. So we thought it would be helpful to talk a little bit about what an executive order is and what it is not. First of all, an executive order is basically, it's a direction from the president to the federal agencies. In some ways, it's kind of like a management memo. It's the president telling the federal agencies that report to him instructions about how they're supposed to function. So it's different from a regulation in that there's no requirement to get public input or anything like that. Yeah, the president can just publish it. Now, an important thing to know about executive orders is that oftentimes they serve more of a symbolic purpose than they actually serve a direct purpose. The reason for that is they're really limited in what type of impact they can have. An executive order has no direct impact on Congress. It has no direct impact on the courts. It cannot conflict with existing law. It might say something that sounds like it can, but if there's a law on the books, that takes precedence over anything that would be in an executive order. It also, an executive order cannot be used to undo a regulation that is already on the books. And what I mean by on the books, a regulation that has been finalized by the agency that published it. So if there's a reg out there and the executive order seems to say that regulation doesn't hold, the regulation does hold. The executive order cannot independently pull that regulation back. And the final thing I think it's important to know about executive orders is that often there's a disconnect or a gap between the one-sentence soundbite you might hear about what an executive order is designed to do and what it will actually do in practice. And there's a couple reasons for that. Sometimes if you just read the fine details in the executive order, you realize that there's a lot of caveats and exceptions and things that don't make it into the one-sentence soundbite. And oftentimes also, even if the president does try to do something, if it conflicts something that Congress has already done or a regulation that's in place, it doesn't happen. So I think that's why it's important to pay attention to some of the details of these things and not get overly concerned about what might be the one-sentence soundbite. So I want to talk specifically about a couple of the executive orders that have been issued that touch on the work that we do. As you may recall, the first afternoon after he was inaugurated, the president issued an executive order around the Affordable Care Act. And if you just listen to the soundbite, it sounded like he was going to upend large chunks of the Affordable Care Act. But this is where it runs into the fact that an executive order cannot undo something that's in a regulation that's already been finalized. And the Obama administration did finalize most of the major regs to implement the Affordable Care Act. So those things, now the new administration can go through the regular rulemaking process and undo a final reg if it goes through the whole notice and comment process, but it won't be able to do that through the executive order. What it can do, what the EO can do, is change processes, administrative processes that are in place that are not dictated by regulations. And we've seen one clear example of that. That has to do with the IRS. As you know, the requirement for individuals to have health insurance or else to pay an individual responsibility payment, aka the individual mandate, that is to be enforced by the IRS. And up until now, the IRS has asked people in the last couple of years if they had health insurance, but they would not reject tax claims that did not answer that question. Starting this year, they were going to reject tax claims that where the person did not, tax returns where the person did not indicate if they had insurance. They've since announced that in accordance with the president's executive order, they will continue to accept tax returns where a person just doesn't state their health insurance status. So there is some concern that this will encourage people not to have insurance because it makes it harder for the IRS to track them down and make them pay the payment. But that, as I said, is something that was not dictated by regulations. We haven't seen anything about CMS regulations being overturned at all. The other major area we've been hearing about executive orders has to do with immigration. And I want to assure people that NAC, all of us at NAC, me, Susan, John, Michaela, Jana, lots of us are following all these executive orders very closely. We're following the ones that actually have been issued. We're following ones that might be rumored to be issued. We are collaborating very closely with other groups that share our perspectives about concerns that these executive orders might have on patients and their comfort level and willingness to seek care. And what I want to make very clear to people, and this gets back to my point about not just taking the soundbite about what an executive order does, nothing has been signed to date by the President that should change how immigrants access care or how you treat them. And I'm just going to repeat that. Nothing has been signed to date that should impact how the immigrants, their comfort level with seeking care from us, or your comfort level in how you treat them. Okay. Moving on to issue of political appointees, we have a confirmed HHS secretary. That's Representative Tom Price, or former Representative Price from Georgia, confirmed earlier this month. He has been a major proponent for the ACA repeal. He, within a week, put out a proposed regulation designed to, quote unquote, stabilize the marketplaces. And by stabilizing the marketplaces, that means to put reforms in place that would make it more attractive for insurance companies to stay in the marketplaces. This regulation was actually in the works under the Obama administration. It has something like an 18-day turnaround. NAC is working on comments on that we will get out to the field. But I will say, honestly, I personally think this reg is a pretty much of a done deal, the proposed reg. But keep an eye out for those comments. Second of all, we do not officially have a CMS administrator on board yet, but the President's nominee, Seema Verma, had her hearing in front of the Senate Finance Committee last week. People fully expect her to be confirmed. She is definitely a Medicaid expert as opposed to a Medicare expert, and she is a strong proponent for state flexibility. She was the architect behind Indiana's 1115 Medicaid expansion, and she supports proposals like premiums on people below 100% of poverty, higher cost sharing, lockout periods, meaning if a person doesn't pay their premiums or co-pays, they get locked out for a certain period of time, linking Medicaid eligibility to work requirements, those sorts of things. So we at NAC will be paying a lot of attention to what is going on with Medicaid 1115 waivers in the future, and you'll be hearing more from us on that as well. Finally, in terms of the HRSA administrator, there's no word yet there on who the nominee will be. Jim McCray is still acting. HRSA is a relatively small fish agency in the grand scheme of things, definitely after CMS, FDA, NIH, so I'm not surprised we don't have a nominee there yet. Finally, I just want to remind you that advocacy is not necessarily something limited to working with the Hill or your state house. Advocacy can also be a very important part of interacting with the administration. And so I'd like to encourage you to bookmark the Policy Shop's blog, and I'll help keep you up to date. For instance, there's a blog post right there now about the executive order on the Affordable Care Act and what its impacts are. And also, we will be sending out updates on the Washington Update. It's a weekly email. So please keep an eye on that as well for activities coming out of the administration. So with that, I'm going to turn it over to John, who's going to talk more about what's going on the Hill.
Great. Thank you so much, Colleen. And hello, everybody. Thank you for tuning in today. I want to start just actually by reminding folks that we have a really in-depth look at all of the issues that we're focused on this year in the 2 earlier webinars in this series. And we'll have links at the end here, and actually the links that Jana covered at the beginning, where you can find recordings of those earlier webinars. We're going to retouch on some of those issues today, but we also want to talk about a couple of new issues or issues that we haven't covered yet that we're going to be focused on the Hill this year. So I think, as we've discussed in the last 2 webinars, really the frame for all discussion of healthcare, probably for the foreseeable future, at least for the rest of this year and probably into next, is what is happening with the question of plans to repeal and replace the Affordable Care Act. And we've actually already gone through pretty substantial changes in how people are talking about that issue, what the conventional wisdom is here in D.C. about how that's going to proceed. I think coming out of the election, there was an assumption by many, including by some of us, that the repeal legislation would be already done and signed by the time the President got back from his inauguration. Obviously, that's not the case. I think there's been an encouraging movement that is really demanding that Congress have a plan to replace the ACA pretty well spelled out before any repeal legislation is passed. And so I think that plan has really changed a little bit, and we just wanted to update with this slide a little bit about where we are now. I think one of the overriding dynamics is that the House and the Senate are probably in more different places than they've been up to date. The House is moving ahead pretty aggressively, I would say, with their continued plan for repeal, also with some replacement elements included. And as we've discussed in the past, this is likely to happen through a process called budget reconciliation, which is basically shorthand for a process wherein Congress can pass things with just 51 votes in the Senate rather than the usual 60. The House has put out a brief that we'll actually be linking to in this week's Washington update just before they went back home to all of you on recess this week, that basically outlines some of their continuing ideas that they intend to introduce as legislation as early as next week. This tracks pretty closely with the Better Way plan, which is the House leadership's plan that we've discussed on past webinars. It includes healthcare tax credits to assist people in purchasing insurance. There still is, I would say, not unanimity within the Republican conference about whether those tax credits should be what's called refundable, meaning that if a person does not pay federal income taxes, they would get an amount of money the way that the ACA tax credits work. That's a big issue that they still are yet to resolve. It also would include provisions around creating health savings accounts as well as high-risk pools to, sequester those folks who are higher risk into their own separate category and insure those pools separately. The funding levels that go along with those items are really still up in the air, and high-risk pools really, the success of high-risk pools really depends on how well they're funded. But probably most importantly to our work and to where we're focused, we do expect that the House plan that could be, again, out as early as next week will contain provisions to convert Medicaid to what they call a per capita allotment, also called a per capita cap, or a block grant system. And as we've talked about in the past, in past webinars, and again, for a much more in-depth look at this, I suggest you go back to those webinars. These systems would really change Medicaid from its current structure, which is as an open-ended entitlement where the federal government pays a share and the state pays a share of whatever the costs are in Medicaid, to a system where the federal contribution to Medicaid is limited, either at the per-person level when it comes to this per capita cap, or at the level of the entire state when it comes to a block grant. The Republicans' proposal, which again we'll be linking in the Washington update this week, does call for both of those options, and that states have the choice of which to proceed with. As we've said before, the issue with a lot of these kinds of proposals is that the devil is really in the details. Not only how do you create a formula to address these kinds of caps and to divvy up that money, but what kinds of required services are preserved, what kinds of things are left to the states. So once a bill is introduced, we'll be doing a really deep dive analysis. We'll be sharing that with all of you, as well as obviously with members on the Hill. And I think we'll be timed well to really be able to speak to this issue, along with the funding issue, when you're all here, or many of you are here at the P&I at the end of next month. As I said, the Senate is in a pretty different place. As is typical, they're on a much slower timeline with a lot of input coming from governors to senators. They're much more concerned about the impact of the Medicaid changes on state budgets. And when you pursue something like a per capita cap or a block grant, what you end up with is oftentimes a real food fight between the states about whether a state fares well, whether a state doesn't fare well, and that is the kind of thing that senators really engage on and are already expressing concerns about, both to us in meetings we're having, but also in public. So that's kind of where things stand in the repeal and replace debate. I just want to return to our sort of key slide that we're using all year to focus on what are the legislative priority areas for us this year. As we've discussed, Medicaid and health center grants really are those highest priority issues. Two pieces, the two pillars that hold up the health center system of care, where there's unique policy to health centers and where, we are in, those issues are both on the table in Congress this year. High priority are also the workforce issues, which we'll talk in a little more depth today, as well as 340B program, which we talked about in some depth on the last webinar. So just to do a quick update on the Medicaid and funding issues, and again, if you are interested in a much deeper look at these issues, I really recommend going back to those past webinars to bone up on it. As we said, the Medicaid debate is really proceeding alongside the larger debate on the ACA. The repeal and replace question is totally intricately tied to the question of what happens with Medicaid, both around the expansion, but also over those kinds of structural changes that I discussed on the last slide. As folks are also aware, we are facing a funding cliff this year, and without congressional action, health centers face a 70% cut in 330 funding, or health center grant funding, if Congress doesn't act by this September to extend our mandatory funding stream. We are feeling like that is likely to, at least right now, appears likely to be proceeding sort of on a separate track. As we've discussed before, there are any number of other provisions, including some of the workforce pieces we'll talk about today, that line up with our funding deadline. The biggest of these and most prominent is probably the Children's Health Insurance Program. Both health center funding and CHIP funding expire on September 30th, and there seems to be, at least right now, bipartisan consensus that Congress wants to address those things well ahead of that deadline. Now, getting to that point is going to take all of the work that all of you are doing and we're doing to really raise the volume on that issue going forward. But I think what's important to remember, and as you make your advocacy plans before you come to town at the end of next month, or if you're not coming to town before you get a meeting with your member on the books, is to really connect the dots for them on the importance and the interplay of 330 funding on the one hand and Medicaid on the other. I think as many folks know who've come to the P&I over the years, you come to town and we talk about funding every single year because it's something Congress has to consider every single year, and in their minds, members of Congress really associate health centers with that grant funding. But as you all know, who are either running health centers, working in health centers, on the boards of health centers, served by health centers, Medicaid is the largest revenue source for health centers nationally. I'm sure this is true for many of you. And we need to continue to do a good job of connecting for members of Congress, the importance of Medicaid to the sustainability and the success of the health centers that they know and love. This is why I think our two pillars argument that Medicaid and health center grants are really the two pillars that hold up the health center system of care. We found that to really resonate in our meetings on the Hill. And again, I think it is fair to say that regardless of the other changes, neither side in this debate wants to see health centers harmed, and so we need to really connect the dots for them on what the policies are that are crucial in order to make sure that that doesn't happen. So a quick advocacy tip. We have some terrific materials that you can use to help calculate the impact of both the funding cliff and the Medicaid program at your health center today. The website is there, hcadvocacy.org. I know folks will be talking about this later, but we have a fantastic new advocacy website with all of these materials and all different kinds of ways for you to engage with your members of Congress. But it's crucially important that you use these tools to be able to take some of the national numbers that we throw around and translate them down into what the impact of these programs is at the local level. So I want to move on quickly to our fourth area, the workforce programs, which again are critical to health centers in every state, territory, and in every single health center. I think more than anything else, our staff hears from NAC members and other health centers about the challenges of recruiting and retaining strong, committed, diverse, dynamic workforce, especially on the clinical side, but frankly on both, the clinical and the non-clinical side, and that is a major barrier that stands in the way of folks being able to really realize the full potential of their health centers. This is something that we were able to quantify a bit last year with the survey and report that we put out just around this time last year called Staffing the Safety Net. This was the result of a survey that went to every health center and really made clear, which was that every health center is struggling, at least at some measure, with a workforce vacancy. 95% of health centers facing at least one vacancy, 70% with a physician vacancy. And importantly, I think we also looked at what was the potential impact of addressing some of these workforce issues in terms of our ability to provide greater access to care. And taken collectively, the survey really demonstrated that if health centers were fully staffed tomorrow, we could serve 2 million additional patients, almost 10% more patients than we're serving today. I think what's tricky about workforce policy is that obviously many different factors contribute to workforce challenges. There are cultural issues within medical training. There are geographic issues in terms of recruitment and retention. But I think also it's really important to say that policy and federal programs specifically are crucially important. So we're going to focus on two key programs that, like the Health Centers program, really they work together with the Health Centers program, and they are also set to expire this year if Congress doesn't act to extend them. So many folks are familiar with the National Health Service Corps, a critically important program that supports clinicians going into underserved areas, going into primary care through both loan repayment and scholarships. More than half of National Health Service Corps clinicians, which this year I think are projected to reach almost 10,000 folks across the country, more than half of those, as you can see, are practicing in health centers today. And like health centers funding for the National Health Service Corps was extended for 2 years in MACRA in 2015. And current funding for that program is around $310 million annually. We'd really like to see not only extension of that funding, but I think an increase in that funding, because even as health center funding has grown, National Health Service Corps funding has stayed relatively flat. And what that means in the field is fewer health centers are able to access clinicians who are supported by the Corps. We know that there are both enough people to there are plenty of people who are interested in joining the National Health Service Corps but can't do so due to lack of funding. We also know that there are many providers willing to hire those folks but also can't get there because their scores are not high enough, and that score is simply a function of the amount of funding that's in the program. The other really important program that we're focused on is the Teaching Health Centers Graduate Medical Education Program. This was a newer program created by the Affordable Care Act and, again, extended for 2 years through the MACRA legislation. THC-GME brings residency training right now just for physicians and dentists, but brings it into the community-based setting. It was really designed to provide an alternative way to fund community-based training outside of the traditional GME structure, where most of that funding goes to hospitals. Most THC-GME sites are health centers, and residents trained in these sites are much more likely to stay and to practice in rural and underserved areas. So, just to return to what is our ask, it's really important, I think, to speak about these workforce programs in the context of leveraging the investment in community health centers. We don't want to fall into the trap where someone says, well, a member of Congress might say, well, you're having a hard time staffing up, why should we even fund health centers in the first place? We don't hear that a lot, to be fair, but I think what we want to say is that these programs work together to really leverage those investments and get them, extend them as far as possible. We also want to ask that they continue and expand support for the National Health Service Corps and for teaching health centers. Some of the arguments that we use around these issues, again, I think relative to some of the savings that they generate and some of the access that they expand, these are relatively small programs. The National Health Service Corps at about $300 million a year, THC-GME currently at about $60 million a year, although we're clear that that amount needs to go up even in order for current programs in order to be whole. But these are relatively small investments that really leverage our larger investment. They expand access, and as we know, primary care really controls costs. I think these programs, it's important to note how crucial they are, especially in rural areas of the country where everybody is facing recruitment and retention challenges, but I think that those challenges are even more acute in rural areas. And that, that there's no silver bullet in workforce. There have to be multiple incentives. We need better training. We need a better pipeline, and that's how these programs work together to really try and address these issues. So one thing I think that is slightly different for the workforce issues versus the way that we work, for instance, on Section 330 funding, is that we really approach all of these issues as coalitions. We work closely with partner organizations on these issues. Just a few of those are highlighted here. The American Association of Teaching Health Centers and NAC obviously work very closely together on the Teaching Health Centers program. Association of Clinicians for the Underserved is really a leader on the National Health Service Corps, and then obviously many of the physician and other non-physician provider organizations and educational organizations we work with together. I think we can help guide you in terms of making connections with affiliates of those organizations at the local and state level, where we've really been maybe be able to really replicate some of these successful partnerships. But I also think telling the workforce story is critical, and I think it's important to note here that you really need to tell both the challenges and the successes, whether they're successes that you've had or whether they're successes that you could have if you were able to fully staff up. It's easy to fall with workforce into a trap of just talking about the challenges, and that's an easy way for Congress to start tuning things out if you just tell them the problem and don't point to the solution that's available. So really connect the dot to what that means for your health center and your patients. So I just want to step back a little bit and talk about where we stand today. I think we are really at a critical inflection point in the legislative debate. When Congress gets back next week, they have said that they will begin marking up legislation, really releasing the first actual detailed legislation on repeal and replace in the House. Now, that may slip a week or two, but I think, we expect that within the first couple of weeks of March at the very latest, we'll actually be working with real legislative text, which signals a real different phase in the overall debate. At the same time, as Colleen noted, as they staff up more and more, the administration will be ramping up their actions, and so March will really be a critical month. Like I said, we'll start to have specifics on repeal and replace efforts. The appropriations process will begin in earnest, and we'll really be rolling out to you all the annual appropriations letter that is a really crucial vehicle to demonstrate the breadth of support for health centers in the House and Senate. And then, of course, the NAC Policy and Issues Forum starts March 29th. I think it's going to be really well-timed this year. I think we're going to be right in the middle of so many of these crucial legislative debates. And, I just can't encourage you all enough. If you're on the fence about coming, if there was ever a year to make sure that you're here in D.C., this is it. And so please, take the time, consider that trip, and please join us here at the end of March. In terms of your preparation, that's what our next section is going to be about. But again, just as you try and get ahead of the curve, make sure that you're ready to tell your story. Going back to those calculators, make sure you're ready to tell that story with data. That's the last bullet there, that you've run the numbers and can speak to what some of these changes mean. And make sure that you're already in touch with your member's office, whether that's about scheduling a P&I visit, whether that's about setting up a visit for back home. It's really important to be in sort of ongoing communication with your member of Congress's office. So on that note, I'm going to send it back over to Elizabeth and the advocacy team to talk about our new website and some of the other action steps going forward.
Thanks so much, John, and thanks everybody for being on the webinar today. I'm going to switch gears a little bit to talk about what I consider the fun part of all of this and all the challenges and opportunities, which is what we can do right now. How can we address those challenges? How can we raise our voice and be heard on all of these issues that are so important to us? But before I jump into our newest action steps, I did want to sort of reiterate what John mentioned, which was our brand new advocacy website and our brand new fancy logo that you see there on the screen. We are now the Health Center Advocacy Network. And hopefully you saw the email that we sent out earlier this week that introduced all of that. It has the links in there to the new website, which is also at the bottom of this slide, hcadvocacy.org. But we're really excited about it, and hopefully you will find it easier to engage with us, with your members of Congress, and to access the tools and resources that you need for advocacy. So please do check us out there. So if you've been around in the advocacy world for a while, you probably remember that we usually put out a menu of action items that you can take, so that there's not just one way to get involved to head off some of the challenges. So the 3 steps that we're asking folks to take right now are to create an advocacy plan, to collect support letters from your state legislators, and to engage your network. And we're going to go into these each in a little bit of depth, but please know that all of the steps, templates, additional resources are available to you on our new website, which is the URL at the bottom there, hcadvocacy.org/makethecase. So the first step is creating an advocacy plan. And really the point of this is to help you get organized and sort of coalesce around the who, what, when, and where of your advocacy activities, as well as to track your progress and success. As I said, the new website has resources for you. There's an outline and a template advocacy plan for you to follow so that you're not reinventing the wheel, and you have suggestions for where to start. We also have the Advocacy Center of Excellence program to help you build a robust advocacy program at your health center, which is beyond just an advocacy plan, although that is one of the touchstones of the program. The ACE program really does serve as a model to institutionalize advocacy and to operationalize your activities. One of the things John mentioned was to do your homework, complete the funding cliff and Medicaid impact estimators so that you're prepared to speak to the local story, you've got the numbers, and you can make the case that way. Those the CLIF and Medicaid impact estimators are also included in the advocacy plan template, so you'll be able to find them there as well as sort of individual items on the website. The second step is to collect support letters from your state legislators. And these letters will speak to the critical role that your health center plays for your patients and the community. Like the advocacy plan, we have templates for both directing one letter to your governor and then a different version for your members of Congress. And we ask that you work with your PCA staff to collect those letters so that there's not a duplication of effort, so that everybody's on the same page and that the voice is even stronger. And to talk about the third step, which was engaging the network, I'm going to turn it over to our social media and advocacy communications guru, Dorian.
I'm hoping you can, hi everyone, it's Dorian. I'm hoping you can hear me. I'm going to advance to the next slide. One of the third steps we would like you guys to take in terms of advocacy is making sure to engage your network and spread the word. On our new advocacy website, we've got a great page that's entitled Spread the Word that has a ton of resources for you to be able to take action and share those actions on social media, represent them on your website, and also engage with your members of Congress on social media platforms. The other thing that we would definitely encourage you to do is establish a recruitment goal and direct advocates to take action, and the action steps are listed on our website, of course. So once again, visit HC Advocacy. We'd love for you to check it out, but also definitely take advantage of those resources. The other thing is we really want to collect and have a lot of stories to show the value of what your health center means to you. So in terms of getting the word out there, we encourage you to use social media. We have something kind of in the works for that, which will be announced later. But in the meantime, you can always email grassroots@NAC.org, or you can submit your story to one of us directly, and we would definitely be happy to share that out on our blog, but encourage you to do that on your websites and social media pages as well. Moving forward, as an individual, you can also take action. As you can see on the side, there's a screenshot there of things you can do to share your actions or to encourage others to do so. We definitely want you to sign up as an advocate. If you're not, please do so. It takes a very quick amount of time, especially on our new site. We encourage you to establish a goal of recruiting 10 advocates, maybe even more. And then, of course, if you are able to do that, encouraging them to share their story. Keep in mind that with our new website, when you have your own personal tracking link or recruiter link, and so if you send that to somebody and they end up signing up, then it will show that you have recruited that amount of advocates. So we'll be able to keep track of your progress, and you can definitely gain some recognition for that. In terms of resources for our advocates, as we've kind of hammered in here, we do have the new website. We also have updated our Facebook and Twitter pages to reflect that as well. So we were formerly Campaign for America's Health Centers. Now you can find us at HC Advocacy on both Twitter and Facebook. So our new website is mobile friendly. It has resources as far as our programming, ways to take action. It has Hispanic advocacy resources, and as Elizabeth mentioned earlier, information about the Advocacy Center of Excellence program, which is increasingly popular and has been a great way for health centers to get engaged. As I just said, it's very easy to recruit advocates via email and on social media, especially with that recruiter button. Our Making the Case page, which is where you can find all of this, also has talking points. It has previous webinars. You can view them or listen to them if you wish. It has our one-page policy paper, the Medicaid Savings Study, and then, of course, it'll have information on the funding cliff and the Medicaid Impact Estimators. You can also share those resources very easily when you visit that page. So if you visit hcadvocacy.org/makethecase, that's where you can kind of find the list of everything that's important right now and what you can do to really stay involved. And if you have questions or you can't find what you're looking for, please feel free to reach out to anybody on the advocacy team, or you can reach out to Federal Affairs as well. The email addresses are listed there at the bottom of the page. I'm going to advance the slide, but I think Jana will be taking over to give you some next steps.
Sure. Thank you, Dorian. We're really excited about all of the brand new website, and we're working really hard to develop as many tools and resources as possible to help you guys make the case. But if there's other issues or things that would be helpful, we're very open to hearing from you. So please share any insights that you have with anyone on the Federal Affairs or Advocacy team or myself. As John mentioned, I really want to underscore this. Next month is going to be a very big month in the health care debate. Both repeal and replace really are expected to be heating up in terms of actual legislation, as well as the appropriations process, which is really critical in keeping our health center funding whole. So there's a couple of really important events that we need for you to mark on your calendar and participate in. The first is the next Policy and Advocacy Update webinar. It's going to take place on Tuesday, March the 21st at 3:30 p.m. Eastern Time. There is a link where you can RSVP for the next webinar. I think because so many things are going to be happening in March, it's going to be really helpful for you to participate in this webinar so you have the latest information and know what's happening on the Hill before you come up here for the P&I for your Hill visits. And then the second thing that we really want to underscore the importance of is your participation in the Policy and Issues Forum. This really is going to be a really critical meeting. The timing is perfect. Both the House and Senate will be in session, so you'll have an opportunity to meet with your members as well as key staff. So take advantage of that opportunity. We need, I think right at this point, we have really strong registration, but the more the merrier, and we're going to need every single health center advocate storming the Hill, arm in arm with NAC and your PCAs at the upcoming P&I. For those of you that haven't already submitted your questions for the NAC staff, you still have an opportunity to do so. Just go ahead and type any questions that you have into the chat box. We have several questions that have already been submitted. So at this point, we're going to do our best to answer as many of those as we can. I'm going to open it up for Q&A and turn it back over to Elizabeth to read out the questions.
Thanks, Jana. We'll go to the first question to Colleen. Where does FEMA Verma stand on PPS?
Where does she stand on PPS? It's really too soon to know for sure. She has not said anything specifically about health centers or PPS. The provisions in the Indiana plan and the other provisions that we know that she's been advocating for tend to focus a lot on what she refers to as personal responsibility as opposed to payment to providers. So we just don't have any information yet to be able to answer that clearly.
Thank you, Colleen. Next question over to John. What is the future of insurance for people with pre-existing conditions? Will people still be able to be on their parents' insurance until 26?
Thanks, Elizabeth, and it's a really good question. I think as most folks are aware, those two provisions are among the most popular provisions of the Affordable Care Act. And I think most policymakers to date have indicated they would like to keep those provisions in some way, shape, or form. The challenge with that is that really those provisions were part of the grand bargain that was sort of at the foundation of the Affordable Care Act, wherein insurance companies stopped discriminating against folks based on pre-existing conditions, allowed folks to stay on parents' insurance, and several other important reforms in exchange for the individual mandate, which required people to purchase insurance, as well as the subsidies which helped them pay for it. And so one of the conundrums I think that's facing Congress right now is how do you, their intent is to repeal both those subsidies as well as the individual mandate. But what does that mean if insurers continue to have to cover things like pre-existing conditions? I think it's one of the reasons and one of the kinds of uncertainty that's caused by the current debate is there isn't an answer to that. And what we're starting to see is insurers, rather than sort of hedge their bets and give it a go, actually exit the exchanges and start to walk away from the Obamacare ACA marketplaces entirely. So I think it's fair to say that in some way, shape, or form, Congress would like to keep those provisions. One sort of variation on the pre-existing conditions issue is that there are proposals, including in Congressman Price's ACA replacement bill, to change that provision to what's known as continuous coverage. So in other words, you would not be able to have a pre-existing condition taken into account in your insurance only if you maintained insurance coverage over a certain period of time. In many cases, 2 years is the time span that they include. And so obviously that's a little bit of a different kind of proposal. It's not a blanket ban on those kinds of provisions. And as many health center folks know, our patients often, because of income, because of other factors, are, what people call churning on and off of coverage. And so this would really affect our people disproportionately, our patients disproportionately. So this is one of many, many issues that we're paying close attention to right now. But I think the bottom line answer is that those provisions are popular, but it's very difficult to keep them when you get rid of all the rest of it.
Thanks, John. And I'm going to actually take a question, and I'm sorry if I was not clear. In my slides, I mentioned working with PCA staff to get those letters of support from your state legislators. And PCA is your primary care association. That's the organization in your state, and there are some regional PCAs as well that really sort of are the knack on the state level, I would say, is a good way to describe it. And if you are unsure of who the best person to reach at your primary care association is, feel free to reach out to us, and we will get you, connected with them. But good question. So next question I'm going to throw to John. What effect would a block grant have on the PPS rate, if any?
So that's a great question, and it's one that we are really continuing to grapple with here in DC. The question is really around a block grant and what effect it would have on health centers' unique payment system. And while we're at explaining abbreviations, I'll just quickly get into PPS for those who weren't on the earlier webinars. But I think most folks are aware health centers have a unique and preferential payment system under Medicaid that is not, it doesn't pay us our costs, but it pays us a predictable, stable rate that covers on average about 82% of health center costs. And that is a federally mandated payment protection that we have. States have to pay health centers their PPS rate, or if they come to a different arrangement, that arrangement has to come out to be at least what the PPS rate would have been. And so the question is, if Congress changes Medicaid to a block grant, what would happen to that protection? The short answer is we don't know currently. There are many different, as I said earlier, the devil is really in the details with these block grant proposals. But the reason that some states are willing to support a block grant approach, which will necessarily mean less money from the federal government, is that it comes typically with the promise of greater flexibility. And we know also that states, by and large, and Medicaid directors, by and large, are not fans of the PPS system and would rather pay health centers less, frankly, for the services that they provide. And so the question is, what does that flexibility look like? If Congress is granting states new flexibility, is that through an enhanced waiver process? Does that just knock out all federal rules entirely? Is it something in between? And that's probably the first thing that we'll really be analyzing when the proposals are released, or certainly are advocating to try and protect even before those proposals are released. But it's a critical question because, if health centers are not able to maintain that PPS protection, either at the state level or the federal level, we've done some rough calculations, but I think on average, we predict it would mean at least 30% less funding going to health centers, and less reimbursement going to health centers through the Medicaid program, which is something that very few health centers could sustain over the long term. So we're going to be working hard to make sure that in whatever version Congress comes out with of Medicaid changes, first of all, that those Medicaid changes don't adversely affect our patient population overall, but secondly, that those Medicaid changes don't adversely affect the PPS system. We're going to have a long way to go on that fight, but that's where we're focused.
Thanks, John. Colleen, I got another one for you. Health centers are contacting their PCAs about the delay of the mega-regs, the 340B mega-regs. Can you give us a little comment on that?
Sure. First of all, I'd just like to be clear that the document that was quote-unquote delayed was actually a guidance. It was not a regulation, and that's an important distinction. What happened was the mega guidance, which was the giant document that the 340B office released in August of 2015. They released it in August of 2015. You may recall, NAC, they received hundreds, if not over 1,000 comments on it. HRSA turned around and had a final version that they had sent to OMB for clearance sometime last fall, and the Obama administration did not issue it as final. And so what is standard operating procedure when a new president comes in is that every draft regulation that's sitting at OMB for final clearance gets sent back to the agency that wrote it so that the new political appointees can review it. So the fact that the HRSA's draft of the final mega guidance was sent back is nothing unusual. It's standard operating procedure for anything that was there when the new crew came in. At this point, now nobody knows for sure, but if I had to lay money on it, I am not expecting to see anything else down the scope of the mega guidance coming out anytime soon. And the reason for that goes back to the executive orders I discussed earlier. One of the executive orders that came out about 2-3 weeks ago required that for every new regulation that is issued, 2 existing regulations need to be rescinded. In addition, there's a strict financial cap on the cost of any regulations that are going to be finalized. Not on the cost to the government, but the cost to society in general. Those 2 provisions put together create a pretty high bar for any agency that is trying to issue a regulation or something like a regulation light, which is what this guidance is. It's sort of like a regulation, but it has a little less the force of law. So I think it will be extremely difficult for HRSA to get any sort of guidance out on 340B anytime soon.